Moving ahead, may I call Dr. Manoj for the next session, please, and may I request Dr. Shankar to chair this session.
He's a specialist in the transcription science practice and has wide range of areas of work and an internationally known speaker. Sir, over to you for this talk on utility of reticulocyte parameters in hematology.
Thank you, Dr. Shankar, sir, for the kind introduction. And my special thanks to the organizing team of Mindray for this Cube 23, and my special thanks to Sama Madam for giving me this opportunity to be on the dais amongst the dignitaries. And at the outset, please let me be clear that this is a very basic presentation, and this is addressed to the fresh colleagues, junior colleagues who are coming into practice, and many of the senior faculties who are sitting here may not find this very appealing, but still we'll go ahead. So what we are going to discuss are utility of reticulocyte parameters in routine hematology. And the definition of reticulocyte is that the reticulocyte derives its name from the reticulum of RNA and protein precipitated by the fixation and staining that appears microscopically after treatment with supravital dyes. And the reticulum network or granules, they represent a precipitated rough endoplasmic reticulum with associated polyribosomes. And we have a very specific definitions for NCCLS, ICHS, which says that reticulocytes must have at least 2 blue staining granules, and this should be visible without fine microscope adjustment. So the granules have to be coarse enough, and they should be seen without fine microscopic adjustment, and they should be located away from the cell margin to avoid confusion with Hen's bodies. So this is a very specific definition which has been given by NCCLS for reticulocyte. The benefit of this official definition is that standardization of the reticulocyte morphology, but this definition does not take into account the wide use of fluorescent dyes that we are using presently in measuring reticulocyte mRNA. So this definition is not addressing the fluorescent dye which we are using. Now we all know that there is an Helmier classification for reticulocytes. Group O is the nucleated erythrocyte, or we know as orthochromatic normoblast, and this is not included into the reticulocyte classification. Group 1 is non-nucleated red cells appearing with a dense clumped reticulum, and they comprise about 0.1% of the population of the reticulocytes in normal individuals. Group 2, if you see, they are extended network of loose reticulum. They comprise about 0.7% of the reticulocyte population in normal individuals. Group 3, if you see the figure there, scattered granules with residual reticulum network, they comprise 32% of the reticulocyte population. And group 4, scattered granules, they comprise 61% of the reticulocytes. So this basic Helmier classification is helpful when we will go to the concept of IRF. Now, there are issues related to microscopic reticulocyte count, and as we have discussed, the standard method is based on the visual detection of granules and RNA ribosomal networks stained by supravital dyes. But there are various sources of impression, and these impression sources are manual counting of reticulocytes, how many reticulocytes you count, how many RBCs you count to go for the reticulocyte count, including different procedures, staining variation, distribution variability for quality of blood film, intra-observer and inter-observer variations, inadequate number of cells counted. So all these add to the imprecision, and this is the reason why we have shifted to automated reticulocyte counts. And most of the manufacturers now, high-end instruments, they offer us the automated reticulocyte count, and the reason for this is the source of imprecision. Now the new methylene blue method and procedure described in the NCCLS ICH H44A2 guidelines still remains the recommended method for agreement correlation assessments when evaluating the performance of automated techniques. So even we have moved to automated techniques, the manual method is still considered as the method of choice when we want to compare the results. Now, as Dr. Sitalakshmi said, we have to derive our own biological reference interval, and this is a big exercise because if you even see the one of the researcher, if you see here, he has derived IRF in different instruments. And if you see the IRF, BRI, all are varying. The same researcher has taken different instruments like Celldines, Janus, Pentra, SE9500, and if you see the IRF, they are varying. So you need to derive your own IRF, and it's a big exercise, and you need proper statistical calculations. And I would request that zone-wise we have to collaborate, and we have to come with our regional BRI. So you can have a regional BRI from West Zone, East Zone, or maybe North Zone or South Zone. And many centers who are having high workload, they can collaborate. We can take the help of the manufacturers, and then we can come out with our own BRIs, which will be useful for reporting this advanced parameters, because we don't get good BRIs in the textbooks, because they are novel parameters and they are not yet included in our standard textbooks. So we have to derive the BRIs. Now, the first of the parameter which we report is the immature reticulocyte fraction. An internationally accepted term is to quantify the younger fraction of reticulocytes. So if you go to that Helmier classification, this could be the group 1, group 2. And some of the populations of high and medium stain intensity is our IRF. And I have given the formula also how the manufacturers, they calculate this IRF. And if you see here, the IRF is basically this high fluorescent and medium fluorescent. Even in that graph, if you see, the HFR and MFR, they are together taken as the IRF. Now, IRF, it is considered as an early marker of engraftment in bone marrow or hematopoietic stem cell transplantation. And several studies have demonstrated that increases in IRF are an indicator of engraftment that precedes other parameters like absolute neutrophil count, reticulated platelets, or reticulocyte counts. So it's a good parameter to demonstrate the engraftment. And in large group of patients undergoing allogeneic hematopoietic stem cell transplant from related or unrelated donors, IRF greater than 10% occurred 1 to 4 days sooner than ANC greater than 0.1 into 10⁹ per liter in most instances. And most of the investigators, they consider that IRF value greater than 10% is indicating an early marrow recovery. Then IRF is also a strong indicator of post-chemotherapy aplasia in children with cancer, serving as an additional parameter of impaired bone marrow function. Then IRF is also used by some researchers to see that it is an early marker of CD34 mobilization for peripheral stem cell harvesting to optimize the timing for stem cell collection for following growth factor mobilization or cytotoxic drug therapy. Then IRF increases have also been used to assess erythropoietic stimulation following erythropoiesis stimulating agents. Then IRF is also used in the diagnosis and monitoring of various anemias, and some of the researchers have used this ratio of reticulocyte count to IRF ratio more than 7.7 as a precondition to screen for hereditary spherocytosis cases. And because IRF increases earlier than the reticulocyte number, it is useful in monitoring the efficacy of therapy in nutritional anemias such as megaloblastic or iron deficiency anemias. So these are all utilities of IRF. And this is a summary slide which tells us where IRF goes high and where the IRF will be low. Then second parameter which is being used is the reticulocyte mean cell hemoglobin content, and different equipments, they label it differently. Some instruments, they label it as CHR, some as Mindray labels it as reticulocyte hemoglobin expression, and some instruments also have the reticulocyte HB cellular, that is RHCC. And studies concerning iron deficiency in pediatric patients, they have demonstrated that measurement of reticulocyte hemoglobin content is helpful in identifying the iron deficiency before the development of anemia. So you are able to pick up the iron deficient stage before the actual development of anemia. Then there are beautiful algorithms which have been devised based on the CHR, and there are 3 parameters which are being looked into. One is CHR, second is the HCT, and then MCV. And these are this is one of the algorithm which is being published to detect iron deficiency in adolescents. And here if you see the CHR, your hemoglobin is not low, but you follow it with CHR. And if this CHR is less than 29, then you see the hematocrit age. Then depending upon the sex, again you give ferrous sulfate, follow up in few months. And then if you have CHR less than 29, consider thalassemia threat, more than 29, continue iron treatment. And if your CHR is more than 29, normal hematocrit, healthy person, low HCT, according you grow. So there are various algorithms which are being published which help us to use this particular parameter in early diagnosis of iron deficiency in adolescents. Then reticulocyte mean cell hemoglobin content, it is also useful in situations of functional iron deficiency and iron sequestration syndromes. And we know that functional iron deficiency occurs when iron stores are transiently unable to meet the demands of increased erythropoiesis, such as those occurring during erythropoiesis stimulating agents treatment. And iron sequestration syndromes occur in chronic diseases when iron is not available for erythropoiesis. And this is, as we know, because of high serum hepcidin level, which determine iron sequestration in the reticuloendothelial system macrophages. So macrophages, they don't allow the iron to be given to the bone marrow. And one of the major determinants of ACD is iron sequestration. So there are various guidelines, as Dr. Sukesh sir was also discussing, and the question was from the audience also, that there are various guidelines which recommend the use of CHR for treating those patients of chronic kidney disease. So you have the Kidney Disease Outcome Quality Initiative of National Kidney Foundation, then British Guidelines for Laboratory Diagnosis of Functional Iron Deficiency, and then the Agency for Healthcare Research and Quality. All of them, they recommend the use of CHR in the treatment, and they recommend a cutoff of about 29 picogram. Then there are various plots which are being published which help us to identify different erythropoietic states of advancing iron deficiency. And they are combining biochemical indicator for iron supply. So you have the biochemical indicator for iron supply, that is this STFR-F index. This is the biochemical indicator for iron supply, and you have the hematological parameter for iron demand. And based on these two, there are plots, and these plots give us the idea about whether there is a functional iron deficiency, whether there is a classic iron deficiency anemia, whether there is latent ID, or there is iron repletion. The only problem with this plot is the cost of the investigation. STFR and ferritin, if you combine, and also the CBC, the cost goes around more than 2,000. And this limits the use of such plots, only the cost. But this is a good plot which will help us to segregate all the 4 different types. Then reticulocyte hemoglobin is also useful in monitoring the efficiency of treatment in iron deficiency anemia. And as we know, the hemoglobin content and volume of reticulocytes, they increase significantly after intravenous iron therapy, reaching the normal values on day 3. And if you see, is one of this case, if you see, the CHR on day 0 is 23.3, then 25.3, then 28, 31.1. So it increases, and simultaneously the reticulocyte volume is also increasing, 98.3, 102, 105, 119. And even on day 4, you can judge that the patient is responding to your treatment. And usually the clinicians, they do the CBC and they evaluate the response of therapy after say 10 days or 12 days. But this is a good parameter which will tell you whether your patient is responding to the treatment or not. And this is a very fast to detect whether your patient is responding to treatment or not. Now there are limitations in clinical utility of this reticulocyte hemoglobin content. And reticulocyte hemoglobin content is decreased in thalassemia syndromes, whereby the reduction in CSR seems to be correlated with the degree of impairment of beta chains. And in other microcytic anemias also, where you have some problems with congenital hemoglobin disease, your reticulocyte hemoglobin content will be decreased. Reticulocyte hemoglobin content will be elevated in iron deficiency patient with confounding megaloblastic anemia because of the higher mean reticulocyte volume associated with megaloblastics. So when you have a combination of iron deficiency as well as megaloblastic anemia, this particular parameter will be not of much use. Then your reticulocyte hemoglobin content, it is increased by drugs using transient or permanent macrocytosis, such as chronic hydroxyurea treatment in patients with sickle cell disease. And therefore, when you are going to use the CHR value, it must be interpreted in context of the patient's overall erythrocyte physiology, including knowledge of recent blood transfusion, iron therapy, vitamin B12 or folate deficiency, chemotherapy, and results of hemoglobin analysis. The last parameter is the reticulocyte cell volume. And reticulocyte cell volume is decreased in iron deficiency anemia and thalassemia syndromes, but reticulocyte count is usually lower in iron deficiency anemia, whereas IRF may be higher in thalassemia. Then reticulocyte volume increases iron deficiency anemia during iron treatment and decreases with the development of iron deficiency erythropoiesis, such as reticulocyte hemoglobin content. In macrocytic anemia, the reticulocyte volume is larger than that of the normal reticulocytes, demonstrating megaloblastic erythropoiesis. And as we know, treatment with vitamin B12 or folate induces a rapid normalization of the volume of reticulocyte, reflecting the efficacy of replacement therapy. So when you are replacing the therapy, this all newer parameters will give you that your patient is improving earlier than the routine what we use MCV or you take hemoglobin. They tell you earlier whether a patient is responding or not. MCR, this mean cell volume, has been measured in sickle cell anemia. Induction of fetal hemoglobin synthesis by hydroxy therapy was associated with increased hydration of sickle reticulocytosis assessed by MCVR. So when you start hydroxytherapy, the reticulocytes will be increasing in size. So automated flow cytometric analysis has led to a significant advance in reticulocyte counting, providing us various parameters like IRF, reticulocyte volume, hemoglobin content and concentration in reticulocyte. And IRF assesses reticulocyte maturation by the intensity of the staining that reflects the mRNA content. And IRF has been proposed as an early marker of engraftment in bone marrow or hematopoietic stem cell transplantation and bone marrow regeneration following chemotherapy. Reticulocyte hemoglobin content, it is useful in assessing the functional iron available for erythropoiesis during the previous 3-4 days, while reticulocyte volume is useful indicator when monitoring the therapeutic response of anemias. These are my references, and thank you everybody for your patient listening.
Thank you, Dr. Manoj Kahar, for a very elucidative talk on reticulocyte and the 4 different parameters which we can use. The baby of the hematology is the reticulocyte,
We can go in other ways, sir. Reticulocyte is the mother of erythrocytes.
You can call like that. I thought of a baby because now I am a grandfather.
But if you say it can be a mother of erythrocytes.
This baby cries at the middle of the night and dumped into your hands. And I try to analyze and find out the reasons for it. One is probably he needs feeding. Second is probably he needs to sleep. Third is probably there is a stomachache. And fourth, he's bored. He has to play. And when he wants to play, you start feeding. And when he wants to sleep, you start doing other things. It's not going to work. So like the reticulocyte, you exactly have to find out what exactly is wrong with it and then give the proper intervention as you have shown through the plots and algorithms. So it has thrown a very elucidative and elaborative talk. The paper is open for discussion and comments.
Yes, thank you for your talk. Very nice. And I would like to make a comment more than a question. You presented the plot, like the Thomas plot, classifying the anemias, and I like that more than the other proposals that says that only with hypochromia you have to give iron. And I think it's better to use CRP, because if you have hypochromia, low CHR, high hypochromic red cells, low MCV, but CRP is positive, is high, I think we need to do ferritin before to give iron.
So in my slide, I had that CRP value also, and basically it is a inflammatory state, and that inflammatory state is leading to release of interleukins, and that interleukins is not allowing your macrophages to deliver the iron to the bone marrow. So CRP, ferritin, all are inflammatory markers, and they will guide you to determine the functional iron deficiency states.
Yeah. But
So
the point,
other biochemical parameters have to be taken in association with the CHR or reticulocyte hemoglobin expression.
yeah, but I like it, this plot, because we don't have to forget the immunochemistry parameters that are very useful before to administrate iron.
But the problem with this plot in our country is the cost of the investigation is quite high, because if you take soluble transferrin receptor, if you take ferritin, if you take the CBC, it goes around 2000 plus. So it's a limiting to use this plot.
Okay, thank you.
Okay.
Yeah, any other questions? Sir, two things I have taken home from your your talk. One is that we should be aware of the various types of dyes which they use in each instrument, and it's very varied, and the techniques they use is also quite widely different. And validation, I am sure, has to be done. Second, of course, is the regional VRI which you have been suggesting regarding collaboration in this. I think that's also a very nice suggestion, and I request the house to take a positive response.
So we need to have collaborations in the different areas of, and that to be the high workload centers have to collaborate and come with a BRI which can be useful for that particular zone.
I think that's a
And if you see the one of the slide I had shown, the researcher, one researcher, he has used the different instruments and he has got the BRI different for all the IRF.
Exactly.
Okay, thank you
very much, sir. Thank you.
Thank you very much.